Hello, good morning. I think we're just missing. Give it another 30 seconds and get going. Oh, there we go.
What?
All right.
Hold on. Audio.
All righty. So moving along in our movement through the antiarrhythmic agents, this week we're going to do beta blockers, which is the class 2 Vaughan Williams group. And there are many beta blockers, but these are probably the most commonly used ones: atenolol, bisoprolol, carvedilol, metoprolol, propranolol, esmolol, and I'm missing actually one, which is nadolol. So those are the main ones. So beta blockers' mechanism of action is that they competitively inhibit catecholamines from binding to the beta 1, 2, and 3 receptors. So what are these receptors? The beta 1 receptors are primarily found in heart muscle. Activation of these receptors results in increased heart rate, contractility, AV conduction, and a decrease in AV nodal refractoriness. So you could imagine, therefore, what the effect of blocking beta 1 are, and this is the most common, I would say, receptor that we're working on attacking when we use beta blockers. Beta 2 are present in heart muscle, but are more prominent in bronchial and peripheral vascular smooth muscle, and activation of these receptors can result in vasodilation or bronchodilation. And in similar vein, blocking of them can cause bronchoconstriction. And this is the reason why some believe that beta blockers can be disadvantageous in patients who have reactive airway disease. Finally, beta 3, which you don't think about as much, are found in adipose tissue as well as the heart. Activation of these receptors can mediate catecholamine-induced thermogenesis and may reduce cardiac contractility. Okay. So blocking sympathetic activity in the heart with the beta 1 receptor reduces intracellular CAMP levels and reduces calcium influx. That's the mechanistic manner in which they work. And interestingly, chronic therapy with beta blockers can upregulate beta receptors so that when you discontinue the agent, you can have hypersensitivity to catecholamines and have pounding of the heart, elevation in blood pressure. Some patients even develop headaches when you rapidly discontinue them. So you have to be careful with that, particularly at high dose. In terms of metabolism, some are metabolized by the liver, such as propranolol and metoprolol. And these enter the CNS more and cause more CNS symptoms. Some are excreted in the kidney, such as atenolol and sotalol, which you remember is not exclusively a beta blocker. It's also a class 3 agent. We're going to discuss that in a few weeks. And these have less CNS symptoms. In terms of adverse effects from beta blockers, they lower heart rate, contractility, and AV conduction. So patients who have bad function, although there are benefits to patients in heart failure, it can worsen contractility. Patients who already have pre-existent problems with their conduction, we would be cautious with their use. And patients who are bradycardic at baseline, we would be cautious with the use. Bronchoconstriction due to beta 2 blockade from the non-selective agents that don't affect only beta 1. An example of that would be nadolol. One would want to be careful with that in asthmatics, although I do believe that although there are certainly patients in whom this is affecting their asthma, it is uncommon in my experience, or at least overly worried. People worry about it a little too much. It can worsen peripheral artery disease and Raynaud's. All beta blockers cause initial fatigue when they're started, but some patients chronically will have fatigue, and it can be a rate limiting step in terms of advancing the dose. Beta blockers, particularly the non-selective ones, can cause neurologic symptoms like nightmares, insomnia, hallucinations, and even depression. A small percentage of patients on beta blockers can develop depression, so one needs to be aware of that, particularly when prescribing them to teenagers. It can cause erectile dysfunction in some patients. And finally, rarely, but not some, but I have seen this, it can cause hair loss in some patients. And it has been a reason that I've had to stop a beta blocker on more than one occasion in a teenage patient. So, in what circumstances do we use these different agents? For patients who have long QT syndrome, first thing to say, I would say, is that probably all agents can be used for all diseases, but there are certain agents that have been studied in certain diseases. And so it is standard to use the agents that have been demonstrated to be effective in those diseases, just because obviously if there's medical evidence of benefit, that would be the agent you would want to use until proven otherwise. So in long QT syndrome, by far the most commonly used agents are propranolol and nadolol. Typically, we use propranolol in smaller children and then use nadolol in older children, mostly because nadolol has a longer half-life and can be given easily as a once-a-day agent in older patients. Now, there are long-acting, extended-release propranolol preparations, but I personally don't have as much experience using them. So typically what we do is we use propranolol until a patient is old enough that they can swallow tablets, at which point we transition them to nadolol. As a young child, like up to about 10 to 12 years of age, the metabolism of nadolol is such that it still probably is best given at least BID. But in a teenage and older patient, it can be safely used once a day, typically in the morning. That's another important point, which is beta blockers typically, in my experience, should be prescribed for the morning, not in the evening. A lot of prescribers give it in the evening because they want the patient to be more compliant with it, and it can sometimes help with sleep. And so it's often prescribed that way, but it is really not sort of giving the medication at the time of most need, which would be during the day, during times of high adrenergic tone. So again, I would encourage you that when prescribing an agent of this nature, that it be at minimum, that it is also dosed during the day. For CPVT, again, we use mostly propranolol and nadolol. And there's quite a bit of evidence that for both CPVT and long QT syndrome, propranolol and nadolol are highly effective at reducing the risk for sudden cardiac arrest and sudden cardiac death from torsade and ventricular fibrillation. Now, for heart failure, the agent that has been studied by far the most is carvedilol, and that is the reason why carvedilol is used for heart failure. I believe that most heart failure experts think that other beta blockers are likely to have similar benefits for patients with heart failure, but because carvedilol was the agent that was in the large-scale studies on this topic, as a general rule, that's the first choice of most heart failure specialists, although oftentimes if a patient is already on a different beta blocker, they won't usually make a change because probably the effects are similar. As you've seen for SVT, pretty much can use anything. Generally speaking, we use propranolol for small children, infants, and the most important reason that we do that is because it comes as a commercially available compound or solution that can be ordered at any pharmacy. So it's very easy to get for patients. It's approved and accepted by most insurance carriers. And so it's also effective, of course. Downside of propranolol is, as you all know, the half-life is very short in infants, and it really formally should be given every 6 hours, but most prescribe it every 8 because of the difficulties and the practicalities of giving a medication every 6 hours. Atenolol is commonly used by many for the treatment of SVT. Not a particularly strong beta blocker, but it really is very selective for beta 1 and less for beta 2. So it's a good agent in that it has very few side effects. Metoprolol is often used by many cardiologists for similar reasons. And then, of course, nadolol is a good agent for SVT, although some might say it's a little bit of a big gun because it's a non-selective beta blocker that has some potential for more side effects. And then if one acutely needs IV beta blockade, the only agent that we should be using is esmolol. Some of these agents can be given IV, but I would make the argument that given the difficulties of dosing it, given the potential for severe hypotension associated with IV beta blockers, really the only agent that should be used, I think, in 2024 should be esmolol. Because it can be it has a very, very short half-life. So if one is not happy with the effect, it can be turned off and gone in a matter of minutes. It's very easy to quickly escalate the dose until you see effect and titrate it to effect. So if one thinks one needs acute IV beta blockade, esmolol would certainly be the first choice. And I would make the argument the only choice. And I would strongly dissuade you from using any of the other agents IV. Propranolol in particular can be given IV. I would avoid that if at all possible because it can cause hypotension. Okay, so that's a sort of a general discussion of beta blockers for today. Any questions about any of that?
Dr. Pastore, what properties of propranolol make it more impactful on the hemodynamics with IV form compared to esmolol? Like, is there anything specific that we should know or?
That's a good question, and I honestly don't know the answer to that, Ivana. What I have seen or what I have read about is that it's very rare that we give it IV, right? I have you ever even used it ever?
No,
Yeah,
I didn't even
right.
know it was possible, honestly.
Yeah, it is. And I believe the dosing is different IV, and I think sometimes people don't realize that. And I think it's really more that it has a longer half-life and it tends to be misdosed as an IV form. And so the problem with any IV beta blocker is that you can just, once it's in, if it has anything like even a 3 or 4 hour half-life, you could end up with an effect you're not happy with and struggle to deal with it. I often, in the adult world, the classic example is labetalol, which is another beta blocker. And some of you may have heard me tell this story. Many years ago, I was involved in a patient who had a post-myocardial infarction VSD, and we were able to close the VSD in the cardiac cath lab, and what I think was quite truthfully a heroic effort. And patient had a great hemodynamic result. Anyway, I performed that procedure from the patient's right IJ because it was an apical defect, and that's often the easiest way to approach an apical VSD transcatheter. Anyway, we were very happy. We were congratulating ourselves, and because the sheath was very, very large, and because it was quite late at night when we did this, we were told by our adult colleagues to bring the patient back to the ICU and that they would remove the sheath, an hour or so later when the heparin had worn down a little bit. And so it was probably around 11 p.m. and I left for the evening and was told that the resident physicians were going to take the sheath out. Anyway, they pulled the sheath out and the patient was very, very agitated as a result of the discomfort from being pushed on the neck through it was like a 12 French sheath. And they gave a dose of IV labetalol, which so profoundly dropped the patient's blood pressure that she arrested and died. Needless to say, it was very tragic. And so I've always had a healthy fear of giving IV beta blockers in general, with the exception of esmolol. So I think that really, some who might listen to what I'm saying would say that they've had very good experience with propranolol IV. And if you're in a circumstance where you don't have access to esmolol, I certainly can imagine that one can develop a experience level using these other agents IV to deliver it safely. I'm sure there was something that was wrong about the manner in which the medicine was dosed, or perhaps it wasn't appropriate for a 90-year-old person who had an MI and had horrendous ventricular function. I don't remember all the details, but I would just say that as a general rule, esmolol has a very nice feature of being able to start at a very, very low dose, and you can very slowly titrate it and see the effect as you deliver it. So I would just say, this comes up occasionally. in the NICU when patients develop necrotizing enterocolitis and they've been on propranolol. And I would just make the observation that if you're that sick that you're in the ICU and being treated for necrotizing enterocolitis, probably you could just pause the beta blocker and just treat as needed with adenosine and things like that in the ICU until you're better. And then again, you have esmolol as an option. So that's what I would say about that. Any other questions I could answer?
Thank you.
No. Okay. All right, let's move on then. So that's class 3. Next week we'll go to that's class 2 rather. Next week we'll go to our start class 3. I think we'll do sotalol next week. Getting to the end of the antiarrhythmics. Okay, so this tracing is one that was on my desk. And the question I have for you, it says normal ECG. And this is a 19-year-old. So I'm going to ask Dr. Kaloff if you believe or agree with the computer evaluation of this electrocardiogram. And you should be aware that I sometimes am tricky and ask a question where the answer is yes, I do agree. So you shouldn't think that just because I'm asking it means definitively there is actually a problem. There could be, but there may also not be. What do you think, Mohammed?
Hi. Good morning, Dr. Bass.
Morning. What do you think? Mohammed, you lost your voice there?
No, I'm here. I'm trying to look at it. The rate.
You should also remind yourself that it is August, and so I'm not going to be asking you about things like twin AV nodes and things like questions I'm going to ask this time of year are going to be fairly straightforward.
Okay.
Look for big things, not little things.
Um, 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 uh, with the QRS on V1, maybe it's not, doesn't look.
It's okay. So are we in sinus rhythm?
So every wave. No, no, like I'm not saying P wave before every.
Well, I think there is a P wave before, right? If you look in this rhythm strip on the bottom, right? I think we could convince ourselves that there's a P wave before each QRS, right? I agree that in some of the leads, it's harder to tell. But do you think it's sinus?
So if we said there's a P before every QRS, and
So that's one important factor in determining its sinus. But what's the other one?
should be upright in one, and
Right. Is it upright in one?
no, it's inverted.
It's inverted. So this is some kind of non-sinus atrial rhythm. So I would not call this normal. I'm not sure I would call it dangerous or worrisome, but it is definitely not sinus rhythm. It's some kind of a non-sinus atrial rhythm. Otherwise, I think the tracing is normal. And you sometimes see this, you know, when someone is at rest, particularly when they're sleeping, you'll sometimes see patients who alternate between what appears to be a sinus rhythm and a non-sinus, maybe a low atrial rhythm. And the old-fashioned term for that is a wandering atrial pacemaker. And this is kind of like that, that you have a rhythm with a lower looks like somehow an inferior atrial rhythm of some sort. So anyways, not that important, but you want to just wanted to drive home that it's not only a P wave before every QRS, but it's also the axis of the P wave that helps determine if you're in sinus. So, all right, good try there.
Dr. Pass, I had a question.
Yes.
For when I'm looking at the lead one, the first P wave that I see in lead one, would you call that inverted, or would you call that, I think it's probably an artifact, but would you call that biphasic?
Well, I think it's hard to say. I think I would say it's inverted because it seems to me unlikely that a P wave that's here is going to conduct to this QRS. In other words, it's so close. The PR would be, if you assume that this part here, which I assume is why you're saying maybe it's biphasic, right? Because it's down and then a little up. I would argue that this is not part of the P wave because if it were, then it would be very hard to understand in the absence of WPW how a P wave could conduct to the QRS in less than 40 milliseconds. The other thing that helps is you have the next beat, which is a much clearer beat, which looks an awful lot like this one, but doesn't have this sort of wavy up area here that's a little above the baseline. And so probably in combination with seeing this beat, I would say that this here is likely not a biphasic P wave, is instead an inverted P wave. Okay.
Thank you.
All right, thank you. All right. So this is a 14-year-old who has palpitations. And my question to you is, what do you think the diagnosis is? So why don't we ask Dr. Bezdakova, who's just joined us from the Olympic Games where she won a silver medal in the balance beam.
Good morning, Dr. Pass.
Morning.
So
Certainly the closest to winning a silver medal of anyone on this call today.
So
I am
looking
correct, right? You were a former outstanding gymnast. Isn't that true?
Yes, I was, and a balance beam was one of my best events, actually.
See, one of the finest athletes in all of pediatric cardiology right here on this call. So welcome. So
Thank you.
what do you think?
So looking at this EKG, I would say it looks like sinus arrhythmia. Looking at the rhythm, so the R to R interval, it looks pretty regular, and
Well, is it really regular?
no, actually,
Quite irregular, I would say.
yeah,
There's a regularity to the irregularness, but it is irregular.
mm-hmm.
What do you think about the P wave axis since we're talking about P waves?
Yeah, so the P waves are inverted into an AVF, so it's not a sinus, not sinus. And then if you look at the rhythm strip in 2, it looks like in going along they're inverted and then they become normal again.
Mm-hmm. So why don't we look at the rhythm strip here? So we have what looks like an upright P wave, so we maybe a sinus P wave. And then we have 2 beats that are clearly different, right? Then we have a pause. Then we have another sinus, so
Yeah.
sinus escape beat. Then we have 2 beats that are different. Then we have a sinus beat. Actually, have 2 sinus beats in a row, followed by 4 of these. So what will we call these little beats here?
Premature atrial contractions.
Yeah, I mean it's some kind of an ectopic atrial focus of some sort, right? Non-sinus, like an EAT. So, okay, so let's say you're in your office and you're in upstate New York and you've just seen this in the office and the patient is saying, I'm feeling palpitations. How would you go about evaluating this patient, Christina?
So
What are
I
you
see.
concerned about and what are you going to do?
So I would be concerned to see them in the office if, this has been long set on the function.
Right.
Um,
So you're worried
uh,
about ectopic atrial tachycardia, right?
yes.
So
Um,
so you understandably, as you just said, you're worried about the function. So you would certainly get an echocardiogram. And what are you looking for on the echo?
I would look if there's a cardiomyopathy or depressed function from the premature atrial contractions.
Right. And
Being
sometimes you can also see dilation of the heart with long-standing chronic tachycardia. So you want to look for dysfunction and also dilation associated with chronic tachycardia. If you saw either of those, sometimes I'll joke that in this particular disease, the echo is almost analogous to the hemoglobin A1C of a diabetic. It helps you have a good sense of what's going on most of the time or chronically. And so yeah, you would get an echo. So let's say the echo looked okay. What else could you do to assess this rhythm?
You could also place a Holter monitor or a Zio on the
Yeah,
patient to see the
absolutely.
degree of burden.
Absolutely. You want to see what the tachycardia burden of this is. In other words, when you're in the office, you only have this 12-second strip, so you don't really know how much the patient is feeling or how much they're having. You also don't even know if this is what the patient is complaining about. They have palpitations. Like, it's always interesting to me. You could see a patient who has 20% PVCs and they don't have any symptoms at all. Then you can have a patient who has 6 PVCs and can tell you exactly when those 6 beats were. They can feel each one of them. So patients are very different in this regard. So we don't actually know if this rhythm we're seeing is what's making the patient symptomatic or not. So yeah, so you would want to get a Holter, and the benefit of the Holter or a Zio would be that it would give you a sense of the burden of tachycardia, what percentage of the beats are that. Could see how fast it's going. You could see if they correlate with symptoms. Oftentimes, patients who have EAT don't feel it except when they're in settings of high adrenergic tone, like exercising or anxiety or something important in their lives where the EAT based because of adrenergic stimulation is very fast and the patient feels it and are uncomfortable from it, even more than usual. And then you would have to decide how you would want to treat this. So what would be the options, Christina? So you've done the Zio. You see that actually 40% of the beats are EAT beats. So how would you advise this? What are your options for treatment of this?
So we can give the patient a beta blocker. So we
Right.
could do nadolol.
Yeah, you could use
is
nadolol or atenolol or metoprolol or even long-acting propranolol. Lots of different options. That's one option.
Mhm.
What else could you do? What are some other agents or other options that you could try?
Could you potentially take the patient for an ablation to see?
Absolutely. Absolutely. So one of the important questions always when someone asks me about ablating EAT is really how much EAT are they having? As you know, when we ablate EAT, it's what we call an activation map, and we're essentially looking for the site in the atrium that is so early that it precedes the onset of the P wave. In other words, you're so close to the spot that there is not enough atrial depolarization to yet cause a P wave on the surface electrocardiogram. And so I think so my point is, if I see a patient who has 8% EAT, my level of excitement at doing an ablation is low because I'm worried that under anesthesia that the patient is going to have even less EAT. And this is one of the few arrhythmias where the patient really needs to have their arrhythmia in order for us to ablate it. And the more examples of the arrhythmia that they have, the better the map is, the more accurate the map is. And so sometimes we take a patient who has EAT and we go to the cath lab and they have 7 PACs over 3 hours, and it's just almost impossible to ablate. Other times, if, for example, a patient like this had the pattern we're looking at on this 12 lead all day long and all night long, I would be relatively optimistic that under anesthesia on the table, we would have lots and lots of ectopy and have a really good shot at accurately mapping and ablating this. But if the patient has very little, then no. So really, one of the benefits of a Holter or a Zio is by giving us the burden of tachycardia, it helps inform a decision about whether or not this is ablatable. The same thing could be said for PVCs. If somebody has, 4% PVCs or 6% PVCs, the chances that we're going to be able to map it are going to be substantially lower than if somebody has, 35% PVCs. Simply, again, because just like EAT, PVC ablations mostly in the outflow tracts are very, very dependent on how much arrhythmia the patient is actually having. And, and that's very different than, say, when we do AV nodal reentrant ablations, tachycardia ablations, or WPW ablations, where we really don't definitively need SVT in order to do an ablation. So the options would be either to start medication, and in your case, you suggested a beta blocker. Other options could be things like flecainide or sotalol, both excellent agents for the treatment of EAT. And then some would say, though, that if you're 14 already and you're having a lot of this, that you should not even screw around with all those meds. You should just take the patient to the cath lab and ablate them. And that's perfectly reasonable as well. And certainly more definitive therapy. Okay, any questions about that? So Christina, is Simone Biles the greatest gymnast of all time as a near professional gymnast? What's your take on her?
Yes, she definitely is.
Yeah, she's quite remarkable. I think she may be the greatest athlete of my lifetime, or certainly she's right up there, top 3. So Serena Williams may be up there, Michael Jordan, a few of them, but she's certainly in that crew for sure. All right, guys, thank you very much. Hope you have a great day. See you and sign out a little bit.
Thank you.
Thank you.
Thanks, Dr.